25-year-old female, refractory multifocal seizures since birth. She presents severe mental, neuropsychological, and motor retardation. She is totally dependent for the activities of daily living and self-care. She underwent vagus nerve stimulator implant without significant improvement at age 21. This is her MRI, and it shows a very severe cortical malformation. Usually in a normal person, we have only one layer of the cortex, and she has this double cortex. See, this is one layer of cortex. This is another layer of cortex. And here we have the sagittal cut of her MRI showing once again the double cortex. So we decided to perform a total callosotomy. So we have decided to perform a frontal craniotomy. So it will give me the access from the rostrum, the genu, the body, and also all the way to the splenium of the corpus callosum. If I perform the craniotomy over this area, central area, I will have to manipulate, retract the motor area, which is probably this not so good. And it also will provide a good angle, but I don't want to touch the motor area. If you go from behind, you can do this too, but the angle probably is not ideal. So I've decided to perform a frontal craniotomy and go like this to perform the total callosotomy. This is a positioning of the patient. So this is the exposure after the right frontal craniotomy and after dissecting the inner hemispheric fissure, and the corpus callosum is already exposed here. So now the inner hemispheric fissure has been opened, the corpus callosum exposed. So let's go to the video. And here, Gelfon again as a retractor. Now when splitting the corpus callosum, and probably we will go into the right lateral ventricle. How do I keep my callosotomy close to the midline? Just follow the septum pellucidum. Anteriorly, if we split the corpus callosum, you can see the foramen Monroe down there. I put cottonoid to prevent blood from going inside the third ventricle. At this stage, genu of the corpus callosum will open laterally. So once again, foramen of Monroe, column of the fornix, choroidal plexus, once again, cottonoid to avoid blood going inside the third ventricle. Continuing the callosotomy posteriorly towards the splenium. We can see here is already at the level of the atrium. Going more posteriorly, I'm going to reach soon. You see that this is anterior wall of the atrium. This is foramen Monroe, column of fornix, choroidal plexus, fornix, thalamus, choroidal fissure. This is at the level of the atrium. The atrium will open laterally, and close to the midline is going to be the splenium of the corpus callosum. So I'm removing the splenium of the corpus callosum down to a very thick arachnoid. See the bluish structure here? That's the vein of Galen. So once again, I was back to the region of foramen Monroe. We know that the column of the fornix here and here it will be the rostrum of the corpus callosum. There's no division between them, so I have to leave a good space anteriorly to, like this, anteriorly to the column of the fornix, not to damage the column of the fornix. Here's the splenium of the corpus callosum, and you will ask me, why did you leave a layer of the white tissue here? Because we have to look for the fornix. So this corpus callosum has been disconnected from the atrium, not the atrium, the rostrum, and then all the roof of the ventricle, which is corpus callosum, has been disconnected, and now the way to this bluish structure, which is the vein of Galen, right under the splenium of the corpus callosum. This is her postoperative CT. She became less agitated, easier to be taken care of by caregivers, and she got over 80% of improvement of the seizures, especially drop attacks.